Change. Sorry. So there is a new entity which has been added to the refractive surgery. Refractive surgery means we'd always think of the corneal-based or the lens-based procedures. Now, last 2 years, we have added up these extra procedures also. Why it's not changing? This for change? No, for change of slide. Ah, okay. Why corneal topography? Topography, because we need to select the right candidate for refractive procedure. There are varieties of refractive procedure. We need to plan the procedure properly. We need to rule out the keratoconus patients. If at all, if we detect early keratoconus patients, we need to plan extra procedure. We need to identify the patients who are more prone for ectasia, and we need topography to monitor the patients post-operatively if they do complain. There are some things which interfere with topography. The most thing is majority of these myopic patients can be contact lens users. It can induce a pseudokeratoconus kind of picture, what you call as corneal warpage. So to identify it and to roll out the dryness, and fixation is very, very important. If you are not able to...
Ananth, you can adjust the mic, Ananth. It's not very clear. Or I don't know whether we are not hearing properly.
The fixation
is
very, very important. Now, we have seen the evolutions of topographies over the years, from Opscan to Cirrus Plus to Pentacam. All the topographies, the basis is on these three parameters. We are considering the elevation, we are taking into the asymmetry into consideration, and the pachymetry. The basis is how far the thickness varies from periphery to the center is the indices. There is a concept called as the best fit sphere. Each and every topographer will subject the patient's anterior or the posterior surface to the imaginary sphere. How far these anterior or the posterior surfaces are elevated from the imaginary sphere is considered as the elevation, which are represented in millimeters or microns. If you go to the first of its topographic find, this is how it would appear, which would give us the elevation details of anterior, posterior, all those things. As I mentioned, if at all, if you are able to identify the asymmetry, superior to inferior more than 1.5 would consider them. And in the thickness in parameters, the difference between the center to the periphery, if it exceeds more than 100, it's like you're dividing the peripheral 7mm thickness from the center. If it crosses more than 1.21, we start thinking that there's an abnormal increase of thickness from center to periphery. We would label them as keratoconus patients. And with this, we would take the elevation data as 40 microns in the post elevation. So we had this sort of charts earlier, but the majority of the refractive surgeons, we do not use topography now. There is evolution, so we have gone to Pentacam. But there is a pseudo elevation changes whenever we are inspecting a patient of keratoconus patient. So there's one more concept called as enhanced best fit sphere, where it rules out the central 3.5 area around the thinnest point. So we have BFS value. We also have what is called as enhanced base of value. This is how it calculates. Whenever you look for these values, the elevation parameters on the interpolation map should be less than 12 and less than 17 on the Pentacam map to call it as a normal patients or ideal patients for refractive surgery. If these values goes more than 15 or more than 17, we start suspecting keratoconus in these patients. Then there is also entity where the Pentacam tells us regarding the difference between the BFS and the enhanced best fit BFS. These values should fall below less than 5 and below less than 12. Beyond this, the Pentacam itself will alert you in the red box telling that this can be a case of very early keratoconus or an hidden keratoconus. Then, as I mentioned you, this thickness parameters, it is nothing but the difference between the peripheral to the central corneal thickness. If it exceeds more than 100, we start thinking that there's a progressive thickening from the thinnest point to the periphery. These two are indicated as two entities called as CTSP and corneal thickness. It tells us how far the percent of thickness is increasing from the central to the periphery. The patient's values are documented in a red line. It should fall within the two black line. If it tries to take a jump from it, then we think that either central cornea is thinner and peripheral cornea is very, very thicker. This can be a case of early keratoconus 2. So to identify the keratoconus much more, there are much more details which pentacams also gives us. If you see there, difference in the front value, difference in the back, the pachymetry progression, thinnest value, thinnest replacement, all the normal values need not to memorize. If they are beyond the normal things, they are represented in the red boxes. To detect keratoconus much more or to identify the candidate suitable for refractive surgery, 4 additional parameters are added to BAT3 criteria. This is which I mentioned regarding thickness. So, see, for example, if the Kmax, if it goes more than 48.2, it alerts us in the red box telling us it could be a case of keratoconus. As I mentioned, in the thinnest point, the elevation should be less than 12 and should be less than 17. I mentioned in this screen, you can see it's around 16 and 45. We start suspecting keratoconus in this sort of patients. So there are few indices to detect much more patients ideal for refractive surgery, what we call as index of surface variance, index of height asymmetry, vertical asymmetry, keratoconus and central keratoconus. Again, these are the same things which are taken into account based on the elevation at the thinnest point, asymmetry from superior to the inferior. The normal values, if they cross beyond the value, again, they are highlighted, then we can suspect the keratoconus patients and we can rule out for refractive surgery. This is the thing which should be kept on the mind. There are index of surface variance which is highly sensitive to differentiate keratoconus from the normalized. This IVA is very clear cut for pre-keratoconus patients. Central keratoconus index, index of height asymmetry. Next. Where? Yeah. So, cirrus topography also works on the same principle. There we call it as keratoconus vertex front and the back, and we call it symmetry index front and the back, but it also takes wavefront into account and beyond some values. This is the topography of my eye and the topography of the keratoconus patient eye, and the normal indices have mentioned the normal. If these wavefront values go beyond this normal, cirrus or cirrus plus also tells us this is a case of early keratoconus or it's a case of normal eye, and we can plan our procedures accordingly. So these are the few case scenarios where you can see early asymmetry and early teardrop sign is starting. It's a steep keratoconus patient. No evidence of keratoconus in patient, just a steep K. Here you can see enhanced specific value is slightly higher. That's why it is indicated in the red. The values are more. If the refractive is very, very less, we can still consider doing a PRK plus for this. Next. So again, early asymmetry is seen. If the refractive is less than 2, we plan for PRK plus. If the refractive is high, we might go in for ICL for this patient. And as I mentioned, topography is also important to monitor the post-op patients to see the ablation profile. And thank you.
Thank you,
For
Dr.
the discussion thing, if you can keep the presentation on, and if you can go back to the pentacam, you keep the same presentations on.
Go back. Same presentation.
Go back to the pentacam thing.
Make it.
So, it's here, I think. And I mean, it is a Herculean task to cover 6 minutes, all the topographies. I think Ananth has done a great job on it. But there are few things which the machine has not put it in the indices. I just want to highlight 2 important things for people to take home. One is every parameter he mentioned for the elevation and all the parameters is based on a Caucasian eye, which has a horizontal wide-to-wide diameters of 12.5. lot of Asians and especially Indians and also the Middle Eastern eyes, we don't have such large white to white. So that many times you may see something like what Ananth said here. You may see some kind of an elevation here, like it's showing as 19 and other things, but your white to white is smaller. So when you have something which looks normal, but having a small white to white here, you have to relook at how you read a pentacam. This is the first point which is important. And the second point, based on our retrospective analysis of many patients where we had a pre-op pentacam from many different parts of the world, and also they had developed ectasia in a near normal when the bad day and other things was normal. One parameter which was very significant was the thinnest location, which is in the XY coordinate. These are Cartesian points. This is X and Y. So when you have the thinnest position, which is moved down on a Y coordinate somewhere here, more than 0.4, it is considered very significant to develop ectasia. That means it is the thinnest point has moved away from the center to a Y coordinate Cartesian points here somewhere at this point of time. These are the two very important indices which is not there in the pentacam report, but it has a huge implication in way we do refractive surgery.
Yes.
Thank you.
Yes. I think as sir told, the thinnest displacement point is also added up there. Whenever these patients come for serial follow-ups, you can just see how far this thinnest point is getting displaced with every follow-up. If it goes more than 0.4, 0.5, then you start considering them as a suspect and you can plan the procedure accordingly. Thank you.
To those of our friends from out of India, Karnataka is one of the largest states in India, and we hold the second highest representation in All India Ophthalmic Society, be it in terms of numbers or with the scientific activity and the awards. It is Dr. Krishna Prasad Kudlu's idea that we have these sessions in multiple other countries forum, and Dr. Rohit Shetty has supported us. It's their whatever seeds they sowed that Dr. Ananth Bhandari and myself are reaping in the society right now, benefits of it. Thank you for that. We have next.
Yeah, we invite the next speaker, Dr. Aparna Naik. She'll be talking about the tackling dexprin membrane detachment. So, Dr. Aparna Naik been a prolific cornea refractive surgeon from a southern part of India. One of the leading hospital called Prasad Netralaya in the coastal Karnataka. So over to you, Dr. Aparna.